Good afternoon or morning or evening, whatever it may be in your world. My name is Ann Brazo. I'm the founder and CEO of MPN Advocacy and Education International. If you've joined us before, we host 12 to 15 webinars per year and 3 in-person events, one coming up next week in New York for women with an MPN. Join us if you can. There are a few seats left. We have lots of good speakers there and look forward to a great event. Today, however, we are going to hear from Dr. Craig Kessler, who is at Georgetown University Medical Center. He spoke at an event we hosted in the spring and talked about what questions MPN patients should be asking their physicians, their hematologists mostly. And it was so fantastic, and we thought it would be great for all of you to join in today to watch his presentation and listen to him and then ask questions. We will field your questions and try to get to all of them. But for now, I'd like you to join me in welcoming Dr. Craig Kessler. Dr. Kessler?
Thank you very much, Ann. It's really a pleasure to be here with you. And thank you for the invitation to speak to your audience. What I'm going to do over the next 30 minutes or 40 minutes is to try to focus in on what we as physicians should be conveying to you as patients, the kind of information that you need when you're deciding on treatment options for your myeloproliferative neoplasm. So just to even the knowledge field a little bit here, I want to just present a little bit of the basics of myeloproliferative neoplasms. And I think all of you are familiar with this concept that the myeloproliferative neoplasms are diseases of the bone marrow. We don't really know the causes yet for the myeloproliferative neoplasms. We'll go into some of what we're thinking about, but we really don't have an answer as to why this is predominantly a disease of aging and why the bone marrow thermostat, so to speak, the bone marrow thermostat is lost as we age, because that's essentially what the myeloproliferative neoplasms are, is a loss of the thermostat, so that the normal regulatory mechanism for making sure we have normal numbers of white cells, platelets, and red blood cells is lost. And when these systems are lost, there's an autonomous growth of these various cell lines, depending on which cell line predominates, is what really determines whether you have essential thrombocythemia or whether you have a polycythemia vera, or whether you have other chronic MPNs such as chronic myelomonocytic leukemia, or even CML, chronic myelogenous leukemia. So you can see on this cartoon that these myeloproliferative neoplasms are really based on the progenitor cells, the grandparent cells in the bone marrow, losing their responsiveness to the internal thermostat that we normally have. And by definition, when cells lose their regulatory mechanism, this is the definition of a cancer. Now, when you go in to see your physician and you're diagnosed with an MPN, the first thing that the physician is going to do, if he or she knows about MPNs, is to check to see what kind of gene mutations that you have in your bone marrow. You can also pick up these gene mutations also in the peripheral blood most of the time. And of course, the gene mutations that we're most interested in for MPNs are the JAK2 gene mutation, the CALR, and the c-MPL. So you want to really ask your doctor, well, what do these gene mutations mean for me? What is the implication? Well, we know that polycythemia vera, that 95% plus of individuals should have a JAK2 gene mutation. There are subclasses of JAK2 gene mutations as well. I'm not going to go into great detail, but if you are JAK2 gene mutated, that is a key designation in the diagnostic profile for P-Vera. If you have ET, essential thrombocythemia, only about 50% or so of individuals will have the JAK2 gene mutation. The majority of other individuals will have the CALR gene mutation and a small percentage with the c-MPL gene mutation. And then if you look at primary myelofibrosis, you'll see that it's sort of a mixture of these gene mutations because oftentimes the myelofibrosis is really representing a transformation of either ET or polycythemia vera into the scar tissue phase of myeloproliferative neoplasm, which is essentially myelofibrosis. So a very small number of people will be what we call triple negative. I think, again, when you talk to your doctor, it's important for him or her to tell you what the implications are for polycythemia vera or ET, predominantly with JAK2. Those individuals are more likely to develop blood clots. The PV over the CALR progresses, have clotting complications. CALR is a little bit better prognosis-wise. c-MPL, there's a small incidence of those individuals who will progress to acute leukemia. We'll talk about that a little bit more in a few minutes. So many patients who have MPNs with these gene mutations are concerned, well, I have this gene mutation, can I pass it on to my children? Well, these particular gene mutations are considered to be somatic. I put this in quotation marks. That means that the genes are not located in the eggs in the ovary or in the semen and sperm, and therefore you did not inherit these diseases from your parents, nor can you pass it on to your children. These are acquired gene mutations. We don't really know how these gene mutations are acquired. We're getting some information that perhaps these are what we call epigenetic gene mutations. In other words, things in the environment might be responsible. So for instance, we here at Georgetown are looking at some of the veterans who have been exposed to Agent Orange or to toxins from burn pits from the Iraqi war. And we're seeing a lot of these individuals who are very young and developing JAK2 mutations, etc. So maybe there are environmental issues that are responsible for this. One of the other issues as you see your doctor is whether or not he or she should be performing a bone marrow examination to make the diagnosis of your polycythemia, myeloproliferative neoplasm with fibrosis or essential thrombocythemia. So because we can pick up these gene mutations in the peripheral blood, we don't always need a bone marrow aspiration or biopsy to make the diagnosis of polycythemia vera or ET, but in order to make the diagnosis of myelofibrosis, we do need to have a bone marrow because that's the only way that we can really see how much scar tissue there already is in the bone marrow. That has implications for prognosis as well as treatment, and also tells us maybe a little predictive information about how likely you're going to need transfusions of packed red blood cells. Now, the other thing that we can learn from the bone marrow early on is how much scar tissue there is to begin with. Sometimes the scar tissue formation can correlate also with the size of the spleen. So if I see a large spleen, then I will be more likely to perform a bone marrow to see whether or not there is correlation in the scar tissue formation in the spleen and liver, as well as in the bone marrow. The other advantage of doing a bone marrow is that we can pick up low levels of other abnormal genetic abnormalities. These are gene mutations that are not common enough to be detected in the blood, in the peripheral blood. But when we do the bone marrow, we actually have enough progenitor cells that we can detect these low frequency gene mutations that have long-term consequence. So for instance, if we see what is called a TET2 or an ASXL mutation, or a LNK or a P53 gene mutation, these gene mutations give us an idea that maybe the disease is much more aggressive than you would think that the disease should be from just looking at the JAK2 gene mutation. That would increase our surveillance strategies over time and might actually encourage us to be more aggressive in the early treatment of your myeloproliferative neoplasm, with the hope that if we can suppress the expression of JAK2 or the other gene mutations such as c-MPL or CALR, that maybe we can also suppress the gene mutations that would be more likely to produce an acute leukemia over time. Now, these clinical studies to prove exactly what I've just told you have not actually been performed yet, but I think that we will be performing these types of clinical trials in the future because they do have clinical implications. So again, just to show you that these gene mutations do have clinical mutations, you can see over here, this is what we call a Kaplan-Meier plot. This tells us what the survival advantages are with each one of these gene mutations. And I'm not going to go into detail except that to indicate that if you have more than one gene mutation, then the implications of decreased survival are much greater than if you only have one gene mutation, where the survival, as you can see in the top copper appearing color graph, indicates that the median survival is much greater than it would be if you had multiple gene mutations. So I think that now that we're in this in the field where we can pick up these abnormal gene mutations more easily, then I think you're going to see us using them going into the future. One of the problems that we have here is that insurance isn't paying for, a lot of people's insurance is not paying for the ability for us to do these next generation sequencing. And that's been a problem for us with some patients who have poor coverage in their insurance. So this is something to be concerned about when you are looking in November to determine during open season which insurance you should be carrying. So essentially then, with these gene mutations, we can begin to take a look at survival implications. And again, the more gene mutations you have, the less good survival that you may have. So one of the issues that we know of also with the myeloproliferative neoplasms is the complications of developing blood clots, either blood clots in the on the arterial side, such as myocardial infarctions and strokes, or on the venous side with deep vein thrombosis and pulmonary embolism. And we use a scoring system. It's a prognostic scoring system. It's called the IPSET scoring system. And we have risk factors that we use to calculate your risk. So if you're over 60, if you've had prior clotting problems, either on the venous side or on the arterial side, if you have diabetes or hypertension, or if you're JAK2 positive. And then taking a look at these total scores, we can use these as a prediction of your probability of developing a blood clot. So you can see that that you can increase your risk by up to 4% per year. That's actually a substantial risk. Again, this is helpful to us because it tells us whether you should be on an aspirin tablet, whether you should be on anticoagulation, should you be more vigorously phlebotomized, should you be treated more aggressively to reduce your platelet number, etc. So these are the kinds of prognostic indicators that we're looking for early on when we're trying to decide what to do for you. One of the other questions that I get very frequently these days is, should I get a COVID vaccine if I have a myeloproliferative neoplasm? So let's take a look at what happens to people who have who have COVID infection versus COVID vaccine. And also, this is applicable to the newer strain of COVID virus. COVID viruses are actually called SARS viruses. And even though there's a lot less attention in the lay press these days about the lethality of the current SARS virus, it happens to be called the flirt strain of COVID that we're dealing with. This flirt strain of COVID is extremely contagious. It is much more contagious, in fact, than the original COVID virus was that we were dealing with 3 years ago. It is much more contagious. If you are over the age of 60, it is extremely contagious, and you are very likely to develop more serious clinical complications if you are over 60. If you have a myeloproliferative neoplasm, you are much more likely to develop a much more complicated version of the virus. And if you are immunosuppressed by virtue of being on a cytoreductive therapy for your MPN, you are much more likely to develop a complication. So if you're on hydroxyurea, if you're on Jakafi, if you're on any of the newer drugs that are being used for myelofibrosis, you are much more likely to develop a clinical complication if you're exposed to these viruses. So if you take a look at the original COVID virus on the left-hand upper graph of figure 1, you'll take a look at the cumulative incidence of death and the cumulative incidence of thrombotic complications, and to the right of that, bleeding complications. So it is clear that if you have a COVID infection, that your likelihood of developing a clot or your likelihood of developing a bleed is increased, and that your death rate is increased if you develop a clot or a bleeding complication. And the same thing in ET, you can see that there's a high death rate, and most of the deaths are in older individuals. Now, I can tell you that there's been rumors in the lay press that you can get these complications and death related to the COVID vaccine itself. This is an overblown, an over-exaggerated fear. There is very little risk of death from the vaccine. There is very little risk of clot from the vaccine. All vaccines are associated with a background incidence of clotting. Even the flu vaccine has an increased risk of of clotting and a very low risk of death, but it can happen. It, however, is extremely low compared to the incidence of bleeding and clotting and complications and death associated with the infection itself. So I recommend to all of my patients that you should be vaccinated. Now, your response, your antibody response, your immune response to the vaccine may not be as robust as it would be if you were not on these cytoreductive chemotherapy or cytoreductive therapies. However, any protection at all is better than none. So I also recommend that if you're going to be in high risk situations, that you should be wearing a mask. So if you're on an airplane and nobody else is wearing a mask, I would recommend that you wear a K95. I do, and I'm not immunosuppressed. And I can tell you that I see patients every day in the hospital here who are COVID positive and who should have taken the vaccine but decided not to. If you do get COVID infections, you should let your physician know immediately. There are different treatments that are available. Unfortunately, some of the treatments that were so immediately reactive to the original COVID infection don't work as well with these, but let your physician decide whether you should be on Paxlovid or remdesivir, the two products that we use mainly for patients who are symptomatic, who develop symptomatic COVID after they've been infected. I might also add that you should be getting your flu vaccine. And if you're over the age of 60, I would recommend getting the respiratory syncytial virus vaccine as well. We know that RSV has been a major problem in Australia over this last summer, which is their winter. And we anticipate that RSV is going to be a problem here in the Northern Hemisphere during our winter. So I would recommend that if you're over 60 or if you're immunosuppressed and over 50, that you get your RSV vaccine as well. So how do I decide on which treatment to start for your polycythemia vera? Well, this is a very good algorithm that a lot of physicians follow. And you can see that we divide you into a high risk category versus a low risk category. And depending on that, we will either just put you on an aspirin and phlebotomize you as necessary, or we will put you on more aggressive cytoreductive treatment. Personally, I like the pegylated interferons because particularly if you have a high variable allele frequency, that's one of the other terms that you should be familiar with. It's called VAF, variable allele frequency. This is what we use to quantify how much of the cells, how many of the cells in your bone marrow or your circulating blood are infected with the gene mutation, particularly the JAK2 gene mutation in polycythemia vera. If you have a low VAF, that is low risk disease. If you have a high VAF, high being I usually consider over 40%, then I put you into a high risk category and I will treat you more aggressively. If you have any of these other gene mutations, then again, I would want to put you on a treatment which is more likely to reduce your likelihood of progression to myelofibrosis or to an acute leukemia. A lot of this is empirical, and there are treatments that there are nuances in the treatments using any of these cytoreductive agents that are necessary to consider. just for one example. If you are a younger individual still of reproductive age, then it's not recommended that we use some of these drugs versus other. The other situation is if you have any psychiatric history of depression, then the use of the interferons is not recommended because a small number of individuals will have worsening of their depression. And there have even been some individuals who have been suicidal after starting on pegylated interferon, either Pegasus or Bez Remy. So again, this takes a little bit of discussion with your physician so that you can have what we call patient shared decision making. And so you understand the risks and the benefits of any treatment that you're going to start. How about if you have essential thrombocythemia? Again, we separate you according to the severity of your disease. And the less severe your disease, the less aggressive we are in the treatment modalities. So we range from observation alone to daily aspirin, all the way to the opposite side of the high risk category of disease, where we would consider using some kind of cytoreductive therapy, oftentimes hydroxyurea, but I can tell you that we also can use the pegylated interferons and other drugs that are available. If you're JAK2 positive, using Jakafi could also be useful. Also combine that with aspirin. Again, shared decision making, looking at your particular patient profile, your medical comorbidities, where you are in life, are you going to be compliant or not compliant, etc., in order to make those treatment decisions. And then myelofibrosis is also a risk stratified treatment strategy here. And I think that what you need to do is to speak again with your physician to make sure that the kind of drug that you use is going to be tailor-made, individualized for your situation. And we have many more options here with myelofibrosis, so that if you are thrombocytopenic, have a very low platelet count, pacritinib is now available on the market. If you have severe anemia, momelotinib is now available. There's no free lunch, however, in taking care of myelofibrosis. In all honesty, it's a very serious transformation of the disease, and there are side effects of the drugs, and there is also less likelihood that you're going to reach your goal. And if you do reach your goal, unfortunately, the long-term benefits of these drugs is not indefinite. And these drugs work for a while, and then typically you lose their effectiveness. So myelofibrosis is a very different kind of disease. And there is always the option of considering bone marrow transplant. So if you are healthy, if you have, if you're lucky enough to be able to find a donor, if you are self-disciplined enough to know that you're going to be out of commission for a little bit of time, then bone marrow transplant is an option. But I would recommend that you go to a center that knows myeloproliferative neoplasms. This is not a treatment that you should just go to any center that does bone marrow transplants. Will hydroxyurea cause me to develop acute leukemia? This is a question that's asked all the time, all the time. I can tell you that the risk is somewhere around 4 to 6%. We don't, the majority of us don't feel that there's an increased risk of leukemia. A lot of the older data that suggested this was from clinical trials where patients had received many other treatment modalities prior to receiving hydroxyurea, and many of those other treatment modalities themselves had an increased risk of developing acute leukemia. We know that ET and polycythemia vera, myelofibrosis, all have their own intrinsic risk of developing acute leukemia. I don't believe that they're really increased by the use of hydroxyurea. This is where next-gen sequencing and looking at other gene mutations in the bone marrow may be very helpful, because if we see other gene mutations, as I alluded to earlier, those gene mutations may be risky gene mutations themselves, and might actually push us toward more aggressive therapy to suppress the genes, or might even push us over to the bone marrow transplant strategies more than just cytoreductive. Hydroxyurea, however, can cause other types of consequences, particularly scar tissue in the lungs and bone marrow suppression and skin cancers, typically not melanomas, but certainly other skin cancers, and also some fevers. So be mindful that hydroxyurea, as innocuous as it is for most patients, can produce complications that your physician should be aware of. Lastly, your physician, particularly if you go to a medical center like mine or others that are specializing in doing research studies, your physician may ask you to participate in a clinical research study. Now, you can see that there are many questions that we've had about the etiology for why these gene mutations occur. You've seen that we don't really understand the best way to treat a lot of patients, that there are a lot of complications that we would like to be able to predict, and yet we don't have the tools and the research studies available. Here at Georgetown, you will be asked if you would like to participate in a clinical trial. Unfortunately, less than about 15 to 20% of patients with MPNs participate in clinical trials, which is really unfortunate, less than you see in other kinds of cancer studies. And we really lack representation for a lot of ethnicities, and we particularly lack information regarding African Americans, Latinos, and Asians. And we don't know whether their responsiveness to treatment is different. We don't know whether they are more likely to develop myelofibrosis or transform their disease, etc. We really need to understand this in order to give you the best approach to treatment. But if you are offered a clinical trial and you're interested, make sure that the motives of the physician who's trying to recruit you are that their motives are pure. Are they receiving money from the drug company themselves to put patients onto the clinical trial? Is this a bona fide clinical trial, or is it a familiarization study that many drug companies offer to try to get the physicians familiar with the drug, but don't really provide very many answers to the kinds of questions that you would want to have answered if you participate in the clinical study? Remember that when you participate in these clinical trials, the physician cannot promise any advantages to you for participation. I can't pay you to participate. I can't promise that your disease is going to be cured by these various drugs. You have to understand that you're participating somewhat out of altruism, but also out of hope that the treatment modality that your doctor is offering you is going to be better than your standard of care. We can't promise that outcome, but we certainly are doing the study hoping that we will have something better than what we currently have available. Now, you have to understand what your commitment is to the study. You have to understand that you have to be compliant. You have to take the drug. You have to allow us to get the blood studies when we need them. If a bone marrow is necessary, we need to have your permission to do a bone marrow in order to know that the drug is working. The best studies are randomized controlled studies, but they may not be practical in individuals who have unusual rare disorders. And the myeloproliferative neoplasms are considered rare cancers. And so we don't have enough patients to be able to do randomized controlled trials. So we may not get the best statistics, but we certainly can get answers that are important for the development of better treatment strategies, and even can tell us the next study how to do that better. And remember that the only way that we can advance our treatment strategies is by performing good clinical trials. So we need participation. We need to know, though, that we want you to know that if you're going to participate, that you're participating in a study that's really going to help all of your future fellow patients who develop this disease. And this is not just to enhance the salary of the physician. This is to help you, not the physician. Now, I think that that's my last slide, and I think we have time for questions. I'll let Anne moderate that so that we can have as many patient questions answered as we possibly can. So thank you for your attention.
Thank you. That was excellent. And we have 100 questions. So I'm going to try to go through as many as possible. And we might have to ask you back, Dr. Kessler, sometime next week, maybe, or thereafter, to answer some more of these questions. Okay, so you mentioned a couple of things that were very important. All of it was very important, but this is a newly diagnosed 21-year-old with JAK2 positive, and this is the mother asking the question. It is her daughter. To better understand what we need to be asking for a young adult with this cancer, as there are different issues and concerns. What should she be doing? I mean, you know, we have been helping young adults and individuals, pediatric and young adult patients. And one of the things we learned was that they were being given the same amount of drug that people, you know, I mean, it's almost like this 500 milligrams of HU and blah, blah, blah. What would you recommend to this newly diagnosed individual?
Well, I have to say that I'm going to speak in generalities. Having never met the patient, never having examined her, and I didn't know, I didn't hear whether she had PV or ET. I suspect ET because most young women will develop ET rather than PV.
Although she is JAK2 positive, but that could still, yeah.
So I don't know whether she's got polycythemia vera or ET, but in younger women, particularly of reproductive age, I think it's important to know that the pregnancy is problematic for several reasons. First of all, we know that there is a higher miscarriage rate, particularly in women who become pregnant with essential thrombocythemia. We know that there is a higher risk of thrombotic complications, particularly since you discussed JAK2 positivity here. We know JAK2 increases the risks of developing blood clots. So in a young female that you've described, I would want to make sure that she has adequate birth control. Now, if you have birth control, we have to make sure that the kind of birth control that she's on is not itself going to be prothrombotic, because we know that the estrogen-based contraceptives are prothrombotic. So in my practice, I would recommend in these young women, IUDs. And there are IUDs that are specifically intended for women who have never given birth before. They are now inserted and they can be in place for up to 3 years. The estrogens and the progestins that are in the IUDs are not absorbed into the bloodstream, so that the risk of developing clots is minimal to zero. And it also helps these women if they have menorrhagia. A lot of young women have heavy periods, and these IUDs help them to be free of heavy periods. So again, a lot of this is individualized care, and really, it's really important to involve the young woman with the physician. And if they're over 18, most of these discussions occur without the parent involved. But if there's good parent-child relationships, I encourage the parent to be available, because the psychological effect of having a diagnosis like this at the age of 18 is devastating to many young women. They begin to wonder what their lifespan is going to be. They begin to wonder whether they're going to be able to have children, get married, etc. So it involves a very concerted effort on the part of the physician to make sure that you have the knowledge that you need.
Right, and a supportive family. And
Right.
I might say too, either this is a mother or father. If there's any way to get to our New York event, which is next week, we are discussing all of these issues that that young women and women, the challenges they have with an MPN and how to mitigate those. And so thank you for that answer. Okay, should my spleen be palpated every time I see my hematologist? And let me just say, I think so. And we did a survey. One of the survey questions was, my hematologist never palpates me.
It's amazing to me, just amazing to me, the number of patients that I have arriving with diagnoses of MPNs where the physician has never laid a finger on the patient that's coming to see me. It is absolutely amazing. They scan the patient, they screen the patient for every gene mutation known to mankind, but do they ever touch the patient? Absolutely not. I think personally, if you go to a doctor who doesn't examine you at some point, that doctor is not the doctor that I would recommend that you continue to see.
Absolutely.
You don't need to be examined every single time you go into the doctor's office, but I like to feel spleens, and I use that as an indicator of treatment response. Okay, and I think that you should ask your doctor, why aren't you feeling my spleen? Why aren't you feeling my liver?
Right.
And why aren't you looking at other issues that may be important in the treatment of my disease?
Right. And we
So
we hosted that event in Asheville, and I'm trying to remember which physician spoke about the liver and how important it is as an MPN
yeah,
patient to know what's happening with your liver. I'm going very quickly now, Craig, because of
okay.
time. Does Medicare cover next generation sequencing? Not to my knowledge.
I don't think it does,
Yeah.
and it's expensive.
Okay. Let's see. Is there any benefit to repeating a bone marrow biopsy? I
Yes,
mean,
there is.
yeah.
Depend if you see changes in your blood that your physician has difficulty understanding, if you see an increase in your spleen size, if you begin to have early satiety as you begin to treat, if you are having a large amount of difficulty modulating your blood counts with the current treatment that you're on, if you're being considered for bone marrow transplant, etc. There are many reasons where repeat bone marrows might be very beneficial.
If you're already taking hydroxyurea, can you still get an accurate measurement of VAF?
Yes. In fact, in the studies that we did with hydroxyurea and with the pegylated interferon, we used VAF, the variable allele frequency, to show that we were getting suppression of the genes with the treatments that we were using.
We're seeing a lot of young people with MPNs these days, and one in particular that I'm very close to is 23 now. He was diagnosed when he was 16, and he's changing. Things are starting to happen. He had PV. So when would you recommend a stem cell transplant?
So if it's PV,
You can't.
I don't think you need one immediately. I'd say that myelofibrosis is really the one that we are most aggressive in doing bone marrow transplants, because bone marrow transplants are the only cure for that MPN. So, or if you have chronic myelomonocytic leukemia, bone marrow transplants are the only cure for that particular disease. For PV and ET, we're much less aggressive going toward bone marrow transplant. We have many other treatment options before that. So I would not consider bone marrow transplant for PV or ET early on.
Okay. Can stem cells from cord blood be used as a treatment option?
Great question.
Yeah.
As the technology is improving and we are learning how to harvest cord blood, it may become an option. Right now, most people don't have cord blood available, and so it hasn't really been studied very much. But if you happen to have cord blood available and the medical center you're dealing with is expert in cord blood transplants, give it a shot.
Okay. Do you recommend using cytoreductive meds for a 64-year-old with JAK2 VAF of 5.2%? I think this says classified as CHIP with no prior clots.
Okay, so if it's CHIP, that's clonal hematopoiesis with indeterminate prognosis. So that means that it's very unlikely at the age of over 60 that some of these gene mutations are going to turn out to be relevant disease-producing abnormalities. So in that 60-year-old person, I'd probably watch and wait.
Okay. This person was diagnosed at age 69 with ET, JAK2, 18 months ago. No symptoms, just high platelets around 800,000 and low iron, but no anemia. He or she is doing well on daily iron and baby aspirin plus HU 500 milligrams 4 times a week. Is there any research to show that HU can cause dry eyes to the extent that it results in corneal scarring, or is that part of the disease?
That's a great question.
Excellent questions.
Hydroxyurea causes a lot of dry mucosal problems. So women will complain of vaginal dryness when they're on hydroxyurea. You can also lose tear formation. Some people develop dry mouth because you can't form saliva. Men have complained of burning on urination, women as well, burning on urination because of the dryness of the urethral tissue. Skin changes occur when you're on hydroxyurea. I don't advise sun exposure. So all of these are complications of hydroxyurea. It's legitimate to ask your physician about them, maybe dose modification or change to a different modality of treatment.
One of the questions we have here is, can I get my bone marrow biopsy results from my physician? Absolutely, right, Craig? You should be
Definitely.
able to get anything you want, any test that's been done, you should be able to have access to that.
Yeah, I don't understand the absence of availability. Most people have patient portals now, and that report should be on a patient portal as well. And you should be asking your physician to sit down with you to explain what the gene mutations mean and what the course of therapy should be. And you can demand a copy, a hard copy of your results, as well as the virtual availability on a patient portal.
Mhm. How long does it take for Bez Remy to take effect or to become effective?
Uh, well, it depends on the dosing strategy that your physician uses. Usually Bez Remy, and whether Bez Remy is used when you're transitioning off hydroxyurea, for instance, or are you starting fresh without having any hydroxyurea or Jakafi on board? So it's a difficult question to answer, but it's usually a ramp up in dosing, so that we ramp up every 2 weeks until we see a bone marrow response. In most cases, I'd say probably between 6 and 8 weeks, you should see some response from the Bez Remy.
Good. And does ET cause bone pain? We've been hearing this forever, bone pain,
Yeah,
bone pain.
it's a
And
good question. And
yeah,
the answer is all three of these uh, myeloproliferative neoplasms can cause bone pain. I oftentimes put my patients on Claritin. I don't know if which is the antihistamine. We found that in patients with cancer who have bone pain, that Claritin helps. And so you may want to ask your doctor about using Claritin to try to reduce the pain of each one of these myeloproliferative neoplasms.
mhm.
Good
Um,
question.
will having vaccinations eliminate someone from a clinical trial?
No.
Can't imagine. Are high,
Oh, I might one other thing. You might
yeah.
want to get your zoster vaccine as well. If you're over 60 and you haven't had zoster, shingles, that
Oh,
you should get your shingles vaccine. Okay.
okay.
Nothing's more miserable than getting complications from shingles.
Yes.
And
Okay.
I would get it before you start Bez Remy or pegylated interferon or even hydroxyurea. It's because once you start those drugs, your your immune system response to infections is blunted for sure.
Mm. Can hydroxyurea cause fevers?
Yes.
And what should one do for those fevers?
Well, Tylenol should help. If that doesn't help, then you may need to move to a different treatment.
Okay. Can a low allele burden transform into high as time goes on?
Yes.
Okay, and what would the genetic predisposition be that would make that happen, if there is one?
Uh, I'm not sure the question.
Yeah.
The low allele burdens can increase to high allele burdens. I don't know that there's a genetic predisposition for that. Maybe if you do next gen sequencing, you'll find P53, TET2 gene mutations, and other gene mutations that may be associated with, by themselves, an accelerated rate of transformation to a cancer or a secondary malignancy.
So, you mentioned familial MPNs, and we, always try to talk about that because there are so many people we know that will say, my grandfather had this, my
Yeah.
mother had this, my daughter now has this. And I know Dr. Fleischman in California is doing familial studies. Dr. Wadley many years ago was doing familial
Yeah.
studies.
Yeah.
And
Joe
I think Bernie
Percal.
Stein and
Yeah. And Joe
or,
Percal in Utah.
yeah,
Yeah.
and Brady Stein,
Yeah.
everybody's looking at it. And I just found a paper that my son-in-law is a geneticist, and he just found something too that talked about familial MPNs and and I'll send that to you, and we'll have it. We actually had it in our last newsletter that it was available, but I know most of the conversation is still that it is acquired. which could be, absolutely accurate. But this person is saying, how do you explain the fact that my family has more than 3 people, that,
Yeah. Well, we know that that happens. It's a very small percentage, maybe 2 to 3%, but it does happen. If you know that you have a relative who has a myeloproliferative neoplasm, then I think it's worthwhile to watch your CBCs more closely, maybe on a yearly or every other year basis. I would not screen children or young adults for gene mutations because the insurance industry does not look fondly on having on insuring individuals who have gene mutations,
Hmm.
and you may be restricted in long-term care or disability insurance policies with a so-called pre-existing illness if you have the gene mutation known.
Yeah.
And so consequently, I would just do regular CBCs for general health purposes. If you see that there's a problem, then maybe you could work yourself up. I would not, out of curiosity, however, do genetic probes at this
Yeah.
point.
Yeah, that's a good point. Great point, actually. So we are nearly out of time here, and I want to thank you so very, very, very
Certainly.
much. We still have a few questions here, but I may email those to you, and if you
Fine.
could email them back, I'll send them out. But I sincerely want to thank you. You have been a shining star to many of our patients and to me and to this organization. And we so appreciate everything that you do for MPN patients, and the care and humility that you have is always so wonderful for our patients.
Thank you. Thank you,
And
Anne. Good
yeah,
luck to everyone on the call, and I'll be happy to answer any of the questions by email. So
yes, thank you.
thank you.
And just
Okay.
one more message out there. Our event in New York is next Friday for women with an MPN, but you'll hear from younger people who have MPNs and from wonderful, wonderful speakers. So join us if you can. Craig, thank you and have a wonderful day. I hope you feel better.
Thank you, Anne. Take
All
care.
right.
Bye-bye.
Bye, everyone.